I thought that I would start with a little overview of auditory dysfunction in ataxia patients in general, and then speak a little about the very small study, very preliminary findings that we have. So I would like to express my acknowledgements to Professor Gary Rance and Dr. Jessica Blakely from the University of Melbourne, who who are our collaborators on this particular study, and then MSc students Claire and Finn, and Ataxia UK, who funded this study. So what I'm going to talk about, as I said earlier, I would like to give a little overview of what is ataxia, because I would imagine that in this group in this audience, most people, when they think of ataxia and hearing problems, think of vestibular ataxia. And I think it is quite a good idea to have a little overview of what are the different ataxias and how they are actually relevant to audiology. Then I would like to moan a little bit about the guidelines for best practice. And as I said earlier, I would like to share our really very, very preliminary results and just think a little bit about where to go from there and what our challenges are. Well, as I already, ataxia. First of all, I am assuming that everybody knows what ataxia is, but it's always good not to assume anything and just go through very simple definitions. So ataxia obviously comes from Greek words, and it means lack of voluntary coordination of muscle movement. So it's actually a very, very non-specific manifestation of any kind of dysfunction of the parts of nervous system that coordinate movement. And as I already said, the most common one that, when we talk with audiology or people who are interested in auditory research, we usually think about the vestibular ataxia. And pretty much I assume everybody knows what that means. That is then some sort of a dysfunction of the vestibular system, and in acute and unilateral cases it usually manifests quite dramatically actually in vertigo, nausea, vomiting. It's quite a acute dramatic illness, and in chronic cases it's usually much more gradual, and the manifestation is usually just sort of balance problems. I'm not saying just balance problems, it can be quite serious, but it's not quite so dramatic. Now, sensory ataxia is something that has to do with ataxia that is due to the loss of proprioception. And proprioception is the sort of sensitivity to the positions of joints and different body parts. And that is generally caused because there is some sort of a lesion in the dorsal columns of the spinal cord. And I don't know whether you've ever come across patients like that, but I personally, from my experience, the most commonly dramatic one is, for example, our patients with neurosyphilis, who have something called trabes versalis, and they have a very, very characteristic walk. And I now apologize for I'm not doing a sort of like from Ministry of Funny Walks, but it really does look very much like the sort of, when I was in a medical school, it was called a rooster walk. So it is a very, very characteristic kind of walk that these patients present. I think in the English literature it's called the stomping gait. And sometimes, as I said already, the lesion is in the dorsal column of spinal cord, but it can also be in the different parts of the brain that receive this proprioception information. And these are obviously cerebellum, thalamus, and parietal lobes. So this is sensory ataxia, and one of the ataxias in our what we were looking at actually are sensory ataxia. So that's why I decided that it's necessary to sort of think what it means. And then the third group is cerebellar ataxias, and these are sort of different three groups. One is the dysfunction of the vestibular cerebellum. It means that the connections between vestibular organ and cerebellum, and that usually impairs the balance and the control of eye movements. And this is the very common thing is that the person has quite a wide gait, and they find it very difficult to stand, for example, when their feet are close together. And even if their eyes are open, they still find it very, very difficult. And now the next group is dysfunction of spinocerebellum. This means vermis and associated areas, and don't worry if you don't know what vermis is, I will show you a picture a little bit later. And this is it's a very typical manifestation of this type of ataxia is something that's called a sailor gait, a drunken sailor gait, because when you look at how the patient is moving, it does look very much like, I don't want to prejudice you against sailors, but it's characterized by uncertain starts and stops, lateral deviations, and frequent falls as well, and sort of unequal steps. So I think from that point of view, it's actually quite a sort of nice, imaginative, creative name. Now, and the last one is the dysfunction of cerebrocerebellum, which means that the main manifestation is that the voluntary movements are disturbed. And very sort of characteristic examples are probably intention tremor, dysarthria. For example, these patients find it very difficult to control the intensity of their voice, and then something called, well, for example, they find it very difficult to do quick movements. They have something that is called dysmetria, which means that they, for example, if they want to are asked to touch their nose, they either undershoot or overshoot. So these are very typical symptoms or manifestations of cerebrocerebellum. So these are all different kinds of ataxias, and as I said earlier, all three groups are actually important in audiology. Now, very, very quickly, just to give an overview, what causes those ataxias? And I think that if we think, not saying necessarily to our own lives, but the most common one probably is an exogenous substance called ethanol, and that is exactly what you get when somebody has had a little bit too much to drink, and this is obviously reversible ataxia, and it affects both cerebellum and vestibular system. But then there are many others, for example, different medications, anti-epileptic drugs, recreational drugs, then also different, for example, mercury. So different exogenous substances may cause ataxia. Then vocal lesions. Very typical examples would be stroke, tumor, MS. So it depends what part of the brain or the central nervous system they affect, and that's how then obviously the manifestations vary. Then Very typical ones are radiation poisoning, vitamin B12 deficiency. As you probably know, this is something that always affects nervous system, hypothyroidism. Then there are different peripheral neuropathies. There may be very specific cerebellar degeneration. And then hereditary ataxia, these are the ataxias that I'm going to talk about today. Then there may also be a cerebellum malformation, which means that there is just a congenital malformation that actually causes the cerebellum to be sort of like compressed. There's something called Wilson disease that is actually an autosomal recessive disease that affects copper metabolism, and that causes that can cause cerebellar ataxia. And then also gluten ataxia. I thought I would just point it out because you probably all heard that everybody's always making fun of those people who can't have any gluten, but actually these can cause real problems. And in this case, this is autoimmune mediated sporadic cerebellar ataxia. Okay, so these are very quickly the etiological factors. Now, when we talk about ataxia and hearing problems, apart, let's sort of leave vestibular ataxia aside for a moment, then I would imagine that some of you may have heard of something called Friedrich's ataxia. Friedrich's ataxia is the most common hereditary ataxia. It mainly affects the sense of their proprioception, but also parts of the brain, like I said earlier, that are actually sort of receptive, should be receptive to proprioception. And it's the important thing here is that it starts quite early. It very often starts sort of around 10 years of age. It can be quite gradual. The presentation can be very different. But it has a whole host of different problems. I have just here mainly sort of listed the most common problems, but very often these patients are very, very disabled. They also have heart problems. They are much more likely to have diabetes. They have vision problems. So it's a very, very disabling and very serious disease, actually. Now, in general, the sound detection is normal in those patients. So very often, even if they complain about hearing loss, when they have a pure tone audiometry done, it can be quite normal looking. However, if they do have hearing loss, then this is something that I don't know about you guys, I haven't seen in any other patient populations very much. The sort of very dramatic low frequency hearing loss. And I have to say that having had, at the end of the day, not so many patients with Friedrich's ataxia, I've seen this audiogram surprisingly often, so that's not uncommon. But what I want to say is that there are very many patients with Friedrich's ataxia who have normal audiograms. Now we know, yeah, sorry?
Why do people get that problem? I mean, many of them go with the low frequency.
Yeah, I was actually thinking, and I don't really know, to be honest, and I think the problem is that because Meniere's can also have that, and I think there may be some sort of neurodegenerative diseases that are, well, I mean, I have no evidence to say it is completely speculation, that are sometimes mixed up with Meniere's for that reason. But sadly, I don't know a good answer for that. I have some ideas, but they are a little,
Because the Meniere's dependent on the pressure on the cochlea.
Yeah, but here there should be no pressure on the cochlea. Very often these people who have this actually have normal autoacoustic emissions. They have actually normal function of outer hair cells. So that is, I think, a very important thing. And that is how you can distinguish between Meniere's and Friedrich's ataxia, because as far as I know, in Meniere's disease, autoacoustic emissions should be absent. But that is, yeah, I will come back to sort of music a little bit later, hopefully. So anyway, so we do know from the previous research that actually a lot of these patients, regardless of what their audiogram looks like, actually show some evidence of disordered neural conduction. So they very often have abnormal ABRs or absent ABRs, and in the presence of normal autoacoustic emissions and cochlear microphones. And as some of you may know, we have decided that we call this condition an auditory neuropathy spectrum disorder. But I will come back to having a problem with that a little bit later. So I was sort of expecting a lot of MSc students, which I don't think I see any. So I thought, well, I will give a little overview of what auditory neuropathy spectrum disorder is. I'm not going to spend an awful lot of time on that, but these are just if you compare typical sensorineural hearing loss and you compare auditory neuropathy spectrum disorder, these are the sort of main differences between them. So the main issue is that the difficulties in speech understanding are well out of proportion compared to the audiogram. The noise affects these patients much more than typical sensorineural hearing loss. Temporal resolution is very severely affected, and frequency discrimination is also affected, especially in lower frequencies. And let's sort of jump over that. There are different models, and then I'm sort of, okay, that's not important. We can come back to that if you want to. Okay, so that is Friedrich's ataxia, and that is not news to people who are interested in this field, that this is what we see in Friedrich's ataxia. At the end of the day, when auditory neuropathy was first described, it was actually described in neurological patients, and some of them were Friedrich's ataxia patients. So that has been known relatively long. Now, that was sensory ataxia. Now, this is cerebellar ataxia, spinocerebellar ataxia. And to be quite honest, I never ever thought that these patients could have any problems with hearing. Because sort of logically, it seemed to me, before I knew a little bit more, that there is no part of their auditory pathway should be affected. So I didn't have any interest in this particular group, even though I had, but never mind. Okay, but so this is a very heterogeneous group, mainly hereditary etiology, and all sorts of different hereditary sort of patterns there, autosomal dominant, autosomal recessive, X-linked, and so on. And the onset in this patient group is much later in life. So it's 40, so let's say 5th decade, 6th decade, something like that. Not like in Friedrich's ataxia. And as I said earlier, I will show you the picture of vermis. Thank you for being patient. Now you see this sort of meat structure there on between two lobes on the cerebellum is vermis. Okay, so this is where the main lesion is in a spinocerebellar ataxia. Now, actually, as I said earlier, we didn't know an awful lot about auditory function in spinocerebellar ataxia. I don't think we still do. There are just very, very few studies that have looked at the ABRs and have seen that there are abnormalities in ABRs in these patients. But so far there are no published studies whatsoever about the functional consequences of spinocerebellar ataxia. So our collaborator Gary Rance has actually shared with us his unpublished data. He had 18 patients with different types of SCA, and he found that, and so 36 years, and 6 of them didn't have any ABR whatsoever, whereas sort of half of the rest had quite dramatic abnormalities. The sort of here the ABR 1 to 5 interval was prolonged in those patients. So that goes with the data that actually there was a little bit of suggestion about that in the literature before. But what Gary Rance also did, what nobody else had done before, was looking at their speech perception. And here there is a slide of, he used CNC phonemes, and this one is shows actually that in a big proportion of patients the score is lower than the 95 performance range for the control group, the matched control group. So he actually showed that there is a problem in some patients with auditory function, in some patients with SCA. Now,
sorry, so is there a relationship between these two things and the more abnormal the ABR to your speech?
Good, yeah, in principle there is, yeah. Now, my big question was, why would cerebellum affect auditory function? And I don't know, maybe you all know and you don't have this element of surprise, but I did, so I shared my element of surprise with you. And actually, what we know now is that cerebellum actually does respond to auditory stimuli. And the most important thing about cerebellum is that it actually is like a sort of internal clock, if you like, used to time precise temporal relationships between motor and sensory domains. Because remember, this is what helps to coordinate those movements. There is this sort of, I mean, internal clock probably isn't a very good word, but I suppose that you can then all relate to that. And in individuals with cerebellar disorder, the sort of temporal perception, not just temporal auditory perception, but temporal perception is a consistent finding. Now the interesting thing, again, maybe everybody else knows that, is that what we know about, for example, the sensory ataxia, we know that this causes timing disruption over the course of milliseconds. So however, in cerebellar patients, the temporal processing deficit is of a different kind, and it appears to affect those sort of ability to judge longer duration over the course of tens and hundreds of milliseconds. So this is the difference. We did have a sort of ambition to try and tease that out. I hope that we will sort of in the future, but obviously very seldom there are sort of very clear cases, and of course in this population, as you can imagine, recruitment is extremely difficult. So I will just jump ahead a little bit. Now, where I come in here is a very straightforward clinical need. Because out of all the ataxia patients that I have ever seen or had any contact with, very often via email, and there is a lot, I have never met anyone who has actually gone to the audiologist who has seen their auditory dysfunction as something potentially different than your garden variety hearing loss. That may be a very distorted view, that the people who talk to me are the ones who feel very unhappy, but most of them have gone to the audiologist, they have had an audiogram, and they have got a hearing aid. And we know already in general population that hearing aid usage isn't terribly good. Then you can imagine, I hope you can imagine, based on what I've said so far, that these people aren't very happy with their hearing aids, because actually hearing aids don't work in this condition. So I was asked to write guidelines for Ataxia UK. They were putting together overall guidelines. Not hearing had never even been in the guidelines, because these people are so disabled, who cares about hearing? But we all know that communication is terribly important. I would imagine no less so for a disabled person. So I had to write the guidelines, and it actually looked really quite, it was quite difficult, because I could come up with the diagnostic suggestions, and you know, I definitely don't think that just doing PTA is a right way to go about it. But when it came to management, I had nothing. Because one thing that we did know from the literature was that hearing aids don't work. But, and even that may be actually a good piece of advice. Please don't give these people hearing aids. But then, what does work? We also know that the benefit from the cochlear implantation is very varied. In general, these patients don't have very good outcomes. That is not to say that we shouldn't consider it, and I want to make that very clear. But that is not, it's not usually a very big success story, and again, we have a very disabled person with all sorts of different needs, so it isn't something that we would easily jump on. And then, out of completely, like my gut feeling, my suggestion was to use FM systems. But actually, when we looked at any evidence, there was no evidence whatsoever. And it is, I know that in the guidelines people just say whatever they fancy very often, as long as they are sort of very clear about it, but actually it doesn't feel very good. It would be nice to have some evidence that actually FM systems may bring some help to these patients. So, you know, and as I said earlier, we have a study that is actually, we just do a little bit of that, and the rest is done in Australia. And one thing that they are very much trying to focus on is trying to come up with a hearing aid that actually has a special signal processing abilities. And so far I know that they have worked terribly hard, but really very, very disappointing results so far. But fingers crossed, you know, this is something that could, you know, be well changed. So we did aim to have 5 patients, and if we had more time, I would tell you dramatic stories of, you know, how everything went wrong, and people who were supposed to come to us went to the hospital the last day and all that. But I will spare you from that. So anyway, we did have 4 patients, so 4 out of 5 isn't that bad. And as you can see, they have, you know, different profile. And the people who have hearing loss had had hearing aids, which did not obviously help them. Okay, and we did a lot of different things, but because the number is so small, I think that it would probably be better to support to present that, you know, those different, for example, temporal processing results when we have the results pooled. But I thought that I would just, as a taster, show you. Show you the two results, or sort of preliminary results, I would say, with FM systems. So here, all our 4 patients were tested with the CNC bone test, and this is in signal in noise. So signal to noise ratio is 0, so that's the most difficult condition. And as you can see, just by looking at it, there obviously is some positive change. Of course, with this very small group, we tried to do statistical analysis, and of course, we didn't get any statistically significant results. But hopefully, let's see what happens when we combine the data. But anyway, it's still very interesting to look at the change, and also think not so much about what is a statistically significant result here, but also just eyeballing it, how clinically significant it is. What difference would that make for a patient? And then the other thing that we did, we gave them FM systems, and then they went away and they reported back to us at 2 weeks and 6 weeks. And these were the sort of from their questionnaire, and the questionnaire is called Abbreviated Profile of Hearing Aid Benefit. Okay, thank you very much. And it looks at different domains: communication in general, background noise, reverberation, and also sort of aversiveness to sound. And again, the higher the bar, the more difficulties they experience, and the lower the less. And again, you can see, I think, very obvious that there is a trend. Of course, again, on statistical analysis, no statistically significant results. But again, as I said, hoping that we can sort of combine the results together, and for the first time actually get some evidence of whether or not this could help those patients, and what does it mean. When you just look at those results, it's very difficult to imagine that only, that they could, for example, really communicate just without any breathing or anything like that. So it's not like, oh, look at that success story. But knowing these patients and knowing that there is nothing for them, I think that it's really, really important to try and offer some support. And last week, when we had this absolutely sci-fi talk, and I asked this question about the signal processing, then of course the answer was, this is such a small population, this is not worthwhile. But once you have met those people, you actually feel, well, it is a little bit worthwhile to try and help them. Now, I can see already Piers getting a little bit jumpy there. So one more thing that I want to say, well, I think it's I don't have to probably spend too much time on saying that we really do need to sort of continue this and try to figure out what is a good management for ataxia patients. But one thing that I actually was hoping that I would quickly say is that I am nosologically confused. And that doesn't mean that I have a sort of nosebleed or anything like that. I think those diagnostic labels are absolutely because when you look at the patients with the same etiology, you can see that some of them have completely beautiful ABRs, for example, yet their other presentation is very similar. And also you know that the etiology is the same, very likely the lesion is in the same place as well. So it's more a question of degree rather than a different entity. And I had a very nice chance to have a quick word with David Moore, who, as we know, is a APD expert, and he completely agreed with me that, you know, it is time for the APD tribe to start playing with the ANSD tribe, and probably also with a hidden hearing loss tribe, because they are not completely different things. It's more of the sort of spectrum of the same thing. Thank you very much.
Anyone like to ask Kai a question?
Can I ask one?
Yeah.
So this is not really about ataxia, it's about the design of our hearing aid studies. That routinely we don't use, we can't use blindness, we don't even use control conditions. But it occurs to me there are occasions when you could probably use a control condition. You could, and I wonder, this might be an example, obviously you give something an FM system, but if you had it set up so that over time it stopped working, they adapted back to normal, every time somebody switches it on, they would hear eventual noise. Over a short space of time, you could have it set up, there are ways of doing it, so that it doesn't produce any noise. So we would have a control to say what, how much is due to the device.
Oh, that's very good. That's a very good idea. Yeah. Of course, we also have to. Yeah, we have to.
Can you repeat the question?
Okay. The question was, you know, how to actually. I mean, how to make it methodologically much more sound potentially in the future. That there is a sort of it's very difficult to have a control for these patients for very obvious reasons. But you could actually have a FM system that switches itself off, and you see a sort of off and on situation. It's a very, very good idea. Did you have a question?
No.
Oh, you were just waving at me. Yeah.
So you said that they've got multiple deficits. Is there a strong association, say, with dyslexia as well? Which there is one theory about abnormal temporal processing causing dyslexia. This is the lack of a feedback link.
I don't think that. Okay, very good. Thank you. Very good question. Whether there is some sort of link to dyslexia in people with cerebellar pathology. I have also read about it, but in this particular spinocerebellar ataxia patients, it's, you know, there is such a list of different symptoms that it doesn't sort of jump up in any shape or form, and that is not to say that dyslexia isn't one of the manifestations.
PhD, did she find that children who have these temporal type problems, the ones that are reading problems?
She hasn't got there yet.
Yeah.
Yeah, I think one more and then, yeah.
Minor technical question. About the FM in the phoneme test, so you had the unaided versus FM.
Yeah.
So how does the FM kind of setup work? Like, you have a microphone by the like, so they're wearing an FM system, right?
Yeah.
But then the stimuli are coming out of a loudspeaker, right?
Yeah.
So is there a microphone like sat near the speaker?
Yeah. Yeah. I mean, you know, the setup was very. We tried to keep it as sort of robust as possible. But the problem, of course, is that these patients are very, as I said, I keep saying it, disabled, and very often there were, you know, there were just difficulties handling the FM system. So it's all very nice to have this in place, but if you, for example, have real problems with just with very, very simple movements, it's not straightforward. So some much more elegant solution would be good.
That was actually a really good point, not what I was thinking of. What I was thinking of is the noise coming out of the same speaker as the signal. So it was phonemes in noise, right?
It must be different. Noise must have come from a different source, right?
Yeah,
so the microphone
yeah.
was closer to the
Yeah.
signal. But not
Yeah.
Okay.
Yeah.
But I wonder if that's why you get kind of like, depending on that kind of setup, can give you maybe bigger results. But
Yeah.
It's a good point. They have to like hand out there, because I guess like in a normal social situation, they have to pass the microphone round, right? So.
Yeah, but you know, again, very often the normal social situations are very limited anyway, and just if their significant other can have a much better communication, would be a big change for their quality of life. Okay.
Okay.
Yeah.
Thank you very much, Kai.